Are you ready to lead in one of the most specialized and demanding areas of medicine? The Neuro Critical Care Fellowship is designed to train you to manage critically ill patients with neurological and neurosurgical conditions. It's a wholly online, one-year American Association of Continuing Medical Education accredited fellowship. Physicians with critical care interest, intensivists, anesthesiologists, emergency medicine, family or internal medicine are qualified. Neurologists and neurosurgeons are also highly encouraged to join the fellowship to gain comprehensive, high-quality, well-structured education in neurocritical care. Fellows are expected to be able to lead the neurocritical care multidisciplinary team upon completion of the program. Core of the fellowship: traumatic brain injury, ischemic stroke, intracranial hemorrhage, subarachnoid and intracerebral, status epilepticus, spinal cord injury, brain tumors and post-operative neurosurgical care, neuroimaging, interventional neurocritical care skills, endovascular treatments like thrombectomy and aneurysm coiling. The program provides experience with managing non-neurological critical illnesses as well. Neuroimaging, focused training in CT, MRI, interventional neuroradiology, exposure to endovascular treatments like thrombectomy and aneurysm coiling, neurology stroke services, acute stroke management, and advanced therapies like thrombolysis and thrombectomy. Topics also include neurophysiology, critical care pharmacology, multimodal monitoring in neurocritical care, post-neurosurgical interventions care, neurotoxicology, brain infections. Become a leader in neurocritical care. Join the fellowship. Save lives. Shape the future.
Hello, everyone, and welcome to our Neurocritical Care Fellowship webinar. This webinar is very special to us, and we have a very nice panel of expertise today, and our focus is the neuro monitoring in brain-injured patients. As we know that traumatic brain injury have a devastating consequences if it doesn't recognized early on, and time is brain. So we have two expert speaker today, Dr. Ahmed Lotfi, who is a critical care physician at King Abdulaziz University Hospital in the Kingdom of Saudi Arabia, and Professor Kaira Ruba, who is a neurocritical care professor in Genoa, Italy. And we have also two great moderator, Dr. Ayman Morayesh, who is a neurocritical care physician and geriatric critical care physician in King's College Hospital, and Dr. Akinola, who is a neurosurgeon from South Africa. Here is our agenda today. So we'll start with Professor Kaira Ruba presentation. She's going to talk about neuromonitoring and TBI. Then Dr. Ahmed Lotfi will give case-based discussion. Then Dr. Akinola and Dr. Ayman Morayesh are going to moderate the session. Housekeeping stuff here. Please, if you have any question or inquiries, feel free to type it in the QA box. All attendees should receive a certificate of attendance by next week. And if you would like to enable the transcription option so you can see whatever we are saying, you can see it typed on your screen, please go ahead and activate the show caption option in the lower part of your screen. I just want to remind you that all of our educational activities are aiming to improve our patients' outcome and improve our clinical practice, because knowledge has no value except we incorporate it and applied it to our clinical practice. And the great aim of education is not the knowledge, but the action. Without further ado, I'm going to introduce our first speaker, Professor Kyra Ruba. Professor Kyra Ruba is a professor of anesthesia and intensive care consultant in the Neuro and General ICU in Genoa, Italy. She has PhD degree in neuroscience, and she is the past chair of the Neuro Intensive Care section in the European Society of Intensive Care Medicine. And she is the deputy editor of the Intensive Care Medicine journal. She published more than 450 peer-reviewed articles, and she published also 2 books on brain and whole body ultrasound. Again, she is also point-of-care ultrasound focus expert. We are going to learn from Dr. Kyra Ruba today, and her presentation should be about 29 minutes.
Hello to everybody. Thank you very much for this invitation. I'm glad to be here with you. And what we are going to do now is to discuss the possibilities of neuromonitoring in brain-injured patients who are admitted to the intensive care unit. I'm Chiara Robba from Policlinico San Martino, Genova, in Italy, and I am the chair-elect of the neurointensive care section of the ESIC. So we have nowadays a huge amount, a large number of neuromonitoring tools that can be used in our clinical practice. And these have different abilities to see different parts and components and physiological status of the brain. And this can be generally divided into two big groups, the invasive and the non-invasive one. I don't have the time to go through all the neuromonitoring tools. I will just discuss the most used in the clinical practice. And the most used one is the invasive intracranial pressure monitoring, which, as you know, can be done through different methods, through an intraparenchymal bolt or an intraventricular catheter. And the invasive intracranial pressure monitoring is nowadays considered the standard of care for the management of brain-injured patients. As you know, there is one only randomized controlled trial which aimed to assess the effect on outcome in the use of invasive ICP monitoring in traumatic brain-injured patients. And this large trial was a negative trial, but this did not change the clinical practice because the methodology, the power of the study have been importantly challenged. And so what we normally know, what we do in neurointensive care is that in selected patients, we use invasive ICP, and this can have an important effect on outcome. This is a large study that we did with the group of Monza, where basically it's an observational study, the Synapse ICU, where we demonstrated that the use of invasive ICP, especially in the most severe cases, can have a beneficial effect on 6 months mortality and unfavorable outcome. Now, question still remains regarding the use of ICP, especially when to use invasive ICP, which are the patients that can benefit from this. The guidelines from 2007 have declared some definitions for the use of invasive ICP, and they recommend to use invasive ICP when the GCS is below 8, so in severe traumatic brain injury patients with an abnormal CT, plus a number of other clinical situations. The subsequent guidelines, the ones from 2016, do not support any more the current standards because of the lack of evidence. And so at the end of the story, this results in a sort of confusion from the clinician regarding when and which are the patients that can benefit from this tool. And this results also from what we have seen in the Synapse ICU study, because this is a more, so this is basically a caterpillar graph, which demonstrates a high variability among centers in the use of invasive ICP. Each one of these is a center, and this is the probability to receive ICP monitoring adjusted for confounding factors. So there is still a lot of variability, despite in neurointensive care, we know that this should be the standard of care. And the other point is when treating ICP, the latest guidelines for the management of TBI just say 22 is the threshold that is recommended. The previous one were telling us 20 millimeters of mercury. The concept that we need to keep in mind is that probably it's not about one number, it's not about the 20 or the 22, but the problem is the physiology and the effect of increased intracranial pressure on the brain. And more recently, there are studies which have demonstrated that the issue is not the number itself, but is the area under the curve, so the time that we spend with an increased intracranial pressure, which is importantly associated with the outcome of the patient. So don't be too worried if for a few minutes the patient goes up to 30 because maybe he's coughing, but be scared if the patient has 25, 28 for a prolonged period of time. And now for ICP, we have, it is an established neuromonitoring tool, so we have a number of algorithms and the clinical recommendation which help us to understand what to do when intracranial pressure is increased. And I recommend you to have a read to this paper, which is the Seattle Consensus, which provides an algorithm of therapeutical approach, which go from tier 1 to tier 3, from less aggressive to more aggressive treatment of intracranial pressure in order to avoid the secondary brain damage. Together with ICP, the guidelines and the recommendation also suggest to have a look and to consider the concept of autoregulation. As you know, autoregulation is the ability of the brain to maintain stable cerebral blood flow despite the changes of cerebral perfusion pressure. And this is what we have studied in our books of physiology. In young and in elderly hypertensive patients, the curve is a bit shifted on the right. The concept now, the idea is that unfortunately the Lassen's curve, the curve of autoregulatory status, is not what we have studied in our books. It's more or less like this, and this picture is telling us that each patient has his own autoregulatory status, as his own Lassen curve. So if I set a CPP of 60, this can be enough for this patient, but could be not enough for other patients. And this leads to the idea to individualize the treatment of autoregulation and the monitoring of autoregulation. And it is of extreme importance because autoregulation is a protective mechanism, and it protects us from episode of systemic hypotension, so from ischemia, hypoperfusion, etc., and episodes of hypertension, which can lead to edema, hemorrhage, etc. So how to individualize the treatment of autoregulation? If we go back to the description of a definition of autoregulation, is the ability to maintain cerebral blood flow despite changes in perfusion pressure. So we need two factors to assess autoregulation: cerebral blood flow, or a surrogate of this, and the cerebral perfusion pressure or arterial blood pressure. Now, the way to measure cerebral blood flow are many. Some are direct, some are indirect. Obviously, the gold standard are the perfusion direct techniques like CTP, the PET, the SPECT, but obviously these are not feasible at patient's bedside. And so what we generally use are surrogate of cerebral blood flow assessment, which can be non-invasive, like, for example, transcranial Doppler, NIRS, or can be invasive, like, for example, the intracranial pressure or the PbTO2. We will go quickly through these methods. In general, when you are at the patient bedside, there are two main ways to assess autoregulation. One is just testing. Testing means that I do something. I manipulate the arterial blood pressure and I see what happens to the cerebral blood flow. So if you assume, like in this example, that the flow velocity measured through transcranial Doppler is a surrogate of cerebral blood flow, we measure arterial blood pressure and the flow velocity in the middle cerebral artery, and then we give a drug. we give a drug which increases the arterial blood pressure. And what we see here is a change in arterial blood pressure, but no important changes in the cerebral blood flow, in the flow velocity. This means that this is a patient who has a preserved autoregulation, because despite the changes of arterial blood pressure, the cerebral blood flow remains constant. Testing is easy, can be done at the bedside. It's not super precise to assess the lower and the upper limits. There are more sophisticated methods which are mainly based on softwares and on the continuous measurement of arterial blood pressure and the output, the indirect method to assess cerebral blood flow. And in these cases, we don't have to do anything. We don't have to manipulate the arterial blood pressure. We just monitor the patient. And if arterial blood pressure and cerebral blood flow go in different directions, it means that the patient is autoregulating properly. If arterial blood pressure and cerebral blood flow go in the same direction, this means that the patient has an impaired autoregulation. Another big family of the neuromonitoring tools are those which assess the cerebral oxygenation, which is a very important point. There are nowadays mainly 3 different types of neuromonitoring tools to assess cerebral oxygenation: jugular bulb oximetry, tissue oxygen probes, and cerebral oximetry. I'll go quickly through each one of these tools. Jugular bulb oximetry basically measures in the jugular bulb, so here, the arteriovenous difference between the oxygen, and it is a non-focal. It is a method which measures a general episodes of cerebral desaturation, and it can be assessed through percutaneous sampling or continuous sampling. And basically, the physiological mechanism is based on this concept. You have basically the oxygen saturation, which is derived from the cerebral metabolic rate of the oxygen. You have an arterial component with 100% of oxygen, and then you measure the amount of oxygen in the jugular vein, and this depends on the cerebral extraction. Now, in normal condition, from a 100% of oxygen, generally there is an extraction of a 25%. But in brain-injured patients, what happens is that there is an increase of the extraction. So from a 100% of oxygen in the arterial compartment, there is a decrease in the jugular oxygen saturation. So this is a method that has been importantly used, and threshold below 50% has been associated with what we call the critical ischemia, so risk of cerebral damage. Normal values are around 65–75%, with desaturation which are considered below 50–55%. It has some strength. It helps a lot to understand physiology, but there are some debates regarding the methodological approach. The jugular bulb the catheter should be placed in a very, very specific position to avoid extracranial contamination. It should be put in the area which is at higher risk of secondary brain damage, and it does measure a global but not a regional desaturation. Now, from this, so like for everything, when you have a number which is provided by the neuromonitoring tools, what you have to do is to think, because you have to put the neuromonitoring in the context of a clinical picture of the patient. And decreased SGVO2 can be related to a number of events, so the therapeutical approach can be importantly different. So the neuromonitoring is not enough itself to guide the treatment. It can help and should be integrated. Now, more recently, brain tissue probes have been proposed for the assessment of cerebral oxygenation. This is basically a small catheter. It is invasive, and basically it measures the flux of oxygen in the extracellular compartment through the Fick equation. So basically it reflects the equilibrium between the diffusion barrier as well as the oxygen tension. Now, there are different companies which have started to provide the brain tissue probes. These are not so widespread used because it is more sophisticated sophisticated advanced monitoring. And as I was mentioning, it's not a measure of the global oxygenation, but it's a measure of a specific zone of the brain. So it's very, very important to assess and to be very good in the catheter locations. And generally in diffuse injury, right frontal lobe can be the right position of a probe. In focal injury, we should be around the pericontusional tissue, which is the one at higher risk of secondary damage. In subarachnoidal hemorrhage should be in the area at higher risk of vasospasm, etc. If put in the right position, it can provide important information. And there are a number of studies which basically have tried to understand whether there is a relationship between the values of PbTO2 and outcome with different thresholds which have been adopted, and I will show you in a second. But these are just some examples, and it seems that in reality, probably ICP itself is not enough for the prediction of outcome, but adding an additional neuromonitoring tool like the PbTO2, this increases a lot the ability to assess and to predict patients' outcome. Because in this study, patients who have, despite the intracranial pressure normal, but who had episodes of desaturation were patients who had a worse outcome. And this is another study, but it's basically the same. Basically here, what you see in over time, over the first 72 hours from admission, you see that patients who died had the median values of PbTO2, which are lower compared to those who lived. And as I mentioned, there is still a bit of debate in the literature regarding the threshold. Generally, what we consider the safe threshold is around the 20 millimeters of mercury, because it is the threshold that is in most cases has been associated with 3-6 ICU outcome. Now, again, we have a number, but we have to think about the cause, because if you want to do something for the patient, then we need a treatment. And to think about the cause and the treatment, what we have to do is to think about the pathophysiology of PbTO2. So we have to think that PbTO2 is determined by the cerebral blood flow, and then from the difference between the systemic PaO2 and the venous compartment, and the oxygen extraction. And so basically there are different causes that can be responsible for cerebral desaturation. An episode of reduction of CPP and therefore of cerebral blood flow, a reduction of systemic oxygenation, a reduction in the oxygen transport, an increase of the barriers to oxygen diffusion. We have to think about the patient in his whole assessment. And this is an example of a very nice patient study from the group of Mauro, which basically demonstrated that there is a direct correlation between the systemic oxygenation and the cerebral oxygenation. With values already below 300 of PF, already there is a decrease in the cerebral oxygenation. And the same group has provided also some information on physiological study regarding the values of hemoglobin. Although there is not still consensus regarding the best hemoglobin target in this patient, there is a randomized controlled trial which is ongoing, but in this physiological study, values of hemoglobin below 9 were associated with a higher risk of cerebral hypoxemia. And this is a review, an editorial that we have just published on intensive care medicine, where we basically summarize all these factors. And we provide also to the readers some information regarding the possible causes and the possible treatment, reduction of CPP, of PaO2, of hemoglobin, and increased metabolism, which can be treated managing sedation of brain temperature, and which allows to put in the clinical context the use of this type of neuromonitoring. There is a third way to assess the cerebral oxygenation. This, compared to the other methods, has the good thing of being non-invasive, and it is basically the NIRS. And it is the NIRS uses basically the near infrared lights, where basically the light is absorbed by pigments. It is absorbed by the oxygenated or the deoxygenated hemoglobin. So the concept is similar to the SJVO2, but it is a non-invasive one. There is a light source here, and then the light source produces a banana shape trajectory, and here there is basically the ability to assess the percentage of oxygen related or not to hemoglobin, so the cerebral saturation. Potentially, it is an interesting tool, and there are a number of companies, and as you can see, it's very easy to put veneers in a patient. It's just putting these two probes non-invasively in the patient's probe. It has a similar function to SgVO2, and the values are similar to those of SgVO2, with the desaturation episodes of desaturation below 50%, which seem to be associated with poor outcome. Now, this tool has been implemented especially in the non-brain injured patients, especially in cardiac surgery or in vascular surgery. The challenge in using this in the Neuro ICU population, in my opinion, is that the optical penetration of veneers in the frontal areas can be importantly affected by the brain injury itself, by the presence of blood, of air, of hygroma, etc. And this can be an issue in the interpretation of the results. But as you can see from this interesting study, the use of RSO2 during cardiac surgery in a huge number of patients demonstrated that it is feasible and that it can predict, it can observe, assess the presence of episodes of cerebral desaturation, and that the episodes of desaturation are associated with significant reduction in neurologic injury when they are treated and with a lower risk of intra-hospital complications. However, we have to be careful. Again, this is a study which basically compared the values of veneers with the values of the PBTO2. And as you can see, there is a large dispersion of the data. The correlation seems quite linear, but it's not very strong. And so we, again, need to be especially careful, especially when we are in brain injured patients. And if I had to assess cerebral oxygenation, I would go for a more invasive but more reliable and more precise methodology. Talking about non-invasive methods, one of the methods that is nowadays one of the most used is the brain ultrasonography. Brain ultrasonography is not just the blind TCD, but is the TCCD, which allows using different windows to assess the intracranial dynamics and to assess the intracranial anatomy. Not of all the brain, if you don't have a decompressed patient, but of some parts of the brain. And this can be applied in a very large number of different clinical applications, and as it can assess autoregulation, ICP, and it can also assess the presence of anatomical alterations like midline shift, hydrocephalus, or intracerebral hematoma. Very easily, and giving you some examples, midline shift is a very, very important issue in neurocritical care. And what we normally do to assess midline shift is to measure the distance with the third ventricle and measure midline shift using this formula, A minus B divided per 2. With the ultrasound, it is possible to insonate the third ventricle. And when we have insonated the third ventricle, we can freeze the image and we can measure midline shift exactly in the way that we do with a CT. Is there a correlation? Yes, there is a linear and good correlation, but always keep in mind that you have in your minds an ultrasound tool, and this means that there are some data dispersion. This means that there might be an inter-observer variability, and then there are some limitations. The same things regarding the presence of intracranial hemorrhage. This is an example of a patient. This is a brain ultrasonography in a patient who arrived after brain injury. This is a small spot of blood, and look here, after a few hours, the patient deteriorated, and this is what we see, an epidural hematoma here with increased of the midline shift. This is quite easy to assess because it was in an appropriate position. And here again, there are some data. There is a good correlation between the values, the volumes evaluated of extradural and subdural hematoma in ultrasound and using CT, both in extradural and subdural. But again, the main limitation might be the insufficient temporal bone, because as I showed you before, with a probe, you can only assess some parts of the brain. Frontal areas, for example, are not able to be estimated with ultrasound. But if you have a patient who is decompressed, and this happens quite often in neurocritical care, you can see a figure which is similar to this. This is an ultrasound evaluation of a brain in decompressed patients. And as you can see here, it is clearly visible the lateral ventricles here. The midline shift is very easy to be assessed. There are here, this is the tip of the external ventricular drain, which also enables to assess the good positioning of the EVD and eventually the presence of hydrocephalus. And this is a quite novel study which few years ago demonstrated that when you have a decompressed patients, all the issues that we have seen in the previous slides regarding the dispersion of the data, here they just disappear. Because as you can see, the correlation between the values estimated through CT and through the ultrasound the correlation is very, very high with very, very small dispersion of the data. And this study compared the estimation of the ventricles, lateral ventricles, third ventricles, midline shift, and also the fourth ventricle. Another application can be the estimation of non-invasive intracranial pressure. Many of you may have heard about the optic nerve sheath diameter. The ONSD is surrounded by the meninges and is full of CSF. So when there is an increase in the pressure here, what happens is that there is a distension in the optic nerve sheath. And this results in an enlargement of this. So some studies have evaluated the use of ONSD in MRI and CT. And now there is a huge amount of authors who are trying to assess the accuracy of ONSD using ultrasound, which is a bedside and non-invasive tool. And this is an example of the image that you can get. This is the optic disc, and just below this, 3 millimeters behind the retina, you can measure the ONSD. Is there a correlation with invasive ICP? Yes, there is. This is a systematic review meta-analysis that we published a few years ago on intensive care medicine, and the area under the curve was around 0.93, the pooled area under the curve, for a threshold of 58, 60 millimeters. And this suggests that this is a tool that can eventually be used. Together with this, we still have our transcranial Doppler, so the ability with the ultrasound to assess the vessels and in particular the flow velocity. And this is of extreme importance because even from the waveform, from the shape of the flow velocity, we can eventually assess the presence or not of intracranial hypertension. One of the simplest methods is the pulsatility index. This is the formula of the pulsatility index. Very easily, when you have increased intracranial pressure, the diastolic flow velocity is decreased, and this results in an increase of the pulsatility index. This is you can measure it mathematically, but you can, when you become a bit expert, just look at the waveform, because here on your left is a normal flow velocity when ICP is normal. When ICP increases, you can see there is a drop in the diastolic component and there is an increase in the difference between the systolic and the diastolic component. Together with the PI, other formulas have been studied. One example of this formula is the one that has been proposed in the IMPRESSIT study, which is now has been confirmed in a multi-center study. And this formula is based on the flow velocity diastolic and on the systemic arterial blood pressure. And this formula demonstrated to be able to exclude intracranial hypertension with a good sensitivity. Again, be careful about the number itself, because there is a bit of dispersion of the data. So if you want to know if ICP is 7 or 10, this might not be the useful tool. But if you want to exclude a patient with possible intracranial hypertension, you can use this methodology, mostly together with other techniques. And the concept is that the more techniques we use and the more accurate we are. This is a study that we did with a group of Cambridge where we used the ONSD, Venous Transcranial Doppler, and TCD, PI, and this formula. And what we observed is that itself ONSD can be the one which has the highest accuracy to assess intracranial pressure. But we also observed in a post-hoc analysis of this study with another study that the multimodal non-invasive monitoring is the way to reduce at best the risk of error. So if you have an ultrasound probe, use all the tools which can provide you an information. And if they tell you the same thing, it's more reliable than using one only method itself. Obviously, the limitations are many, and this is what I have discussed you so far. So that's another reason why it requires training, it requires attention in the interpretation of the data. So in conclusions, I would like to provide you some key messages. In brain-injured patients, the invasive methods are the gold standard. Invasive ICP is the gold standard for the management of these patients. And if we consider cerebral oxygenation, the PBTO2 is the gold standard for cerebral oxygenation. There are also a number of non-invasive tools that can be implemented in these patients and then can help us to understand the cerebral needs. Of course, in non-brain injured patients, we only have the non-invasive methods. We can apply them even in brain-injured patients, but in any case, the suggestion is to use a multimodal neuromonitor approach because each neuromonitoring tool is telling us different things, is giving us different information. And if we want to have a whole explanation and evaluation of the brain, what we need to use is to use as many neuromonitoring tools as possible. Thank you very much for your attention, and I am available for discussion and to answer your question.
Thank you so much, Professor Kaira. Very nice presentation from one of the most eminent and knowledgeable neurocritical care physician in the whole entire globe. And we are going to take the questions by the end of the session. So now I would like to introduce Dr. Ahmed Lotfi, who is a critical care attending at King Abdulaziz University Hospital. Is going to give us some clinical application with case-based discussion for patients with traumatic brain injury.
Hello, everyone. Welcome to our neurocritical care webinar. I am Ahmed Lotfi, an adult critical care physician. Today, we have a case-based discussion session designed to test our clinical understanding grounded on real neurocritical care practice. And now let's start with case scenario 1. A 52-year-old female presents with a Hunt-Hess grade 4 subarachnoid hemorrhage from a ruptured left middle cerebral artery aneurysm. She is post-coiling and is now on post-bleed day 6. She remains comatose and is intubated. You have implemented multimodal monitoring, including an external ventricular drain, transcranial Doppler, and a cerebral microdialysis catheter placed in the left frontal lobe. On day 6, transcranial Doppler monitoring of the left MCA reveals a mean flow velocity of 210 cm per second. The ipsilateral extracranial internal carotid artery mean flow velocity is 30 cm per second. Based on these findings, which of the following is the most accurate interpretation of the patient's hemodynamic state? Mild vasospasm, moderate vasospasm, severe vasospasm, cerebral hyperemia, distal microcirculatory failure. Please submit your answers. And the answer is severe vasospasm. The correct diagnosis is severe cerebral vasospasm, which is defined by a mean flow velocity greater than 200 cm per second and a Lindegaard ratio exceeding 6. In this patient, the left MCA mean flow velocity of 210 cm per second exceed the threshold for severe vasospasm. Calculation of the Lindegaard ratio by dividing MCA mean flow velocity and ipsilateral cervical ICA mean flow velocity yields a value of 7, which confirms that the elevated velocity reflects pathologic arterial narrowing rather than increased cerebral blood flow. And this is a figure showing a transcranial Doppler of temporal window assessing MCA, and the Doppler waveform is showing the peak systolic velocity and the systolic velocity, and this is the equation by which the mean flow velocity is calculated. Cerebral hyperemia is therefore excluded. as it is characterized by elevated MCA velocities with a normal or increased ICA velocity and a Lindy-Gard ratio below 3. So the main difference between cerebral hyperemia and vasospasm is the Lindy-Gard ratio. The figure on the left side is for a patient with increased systolic and diastolic flow velocity and loss of diacritic notch and the Lindy-Gard ratio with a value of 1.98. So it is representing a patient with cerebral hyperemia. The figure on the right side is a transcranial Doppler showing increased systolic and diastolic flow velocity with preserved diacritic notch and a Lindy-Gard ratio with a value of 7.16, representing a patient with cerebral vasospasm. The timing on post-bleed day 6 falls within the peak window for vasospasm following aneurysmal subarachnoid hemorrhage and carries a high risk for delayed cerebral ischemia. Mild or moderate vasospasm would not produce velocities or Lindy-Gard ratios of this magnitude, and distal microcirculatory failure is typically associated with normal or reduced transcranial Doppler velocities. Together, the markedly elevated MCA velocity, high Lindy-Gard ratio, and the appropriate clinical context are diagnostic of severe large vessel cerebral vasospasm. MCQ2. The hourly cerebral microdialysis data from the left frontal lobe shows glucose 0.3 millimole per liter, lactate 4.1 millimole per liter, pyruvate 50, glycerol 316, glutamate 25 micromole per liter, and a lactate pyruvate ratio of 82. How should this biochemical profile be categorized and what does it suggest? Normal brain metabolism, type 1 metabolic distress indicating ischemic or hypoxic disorder, type 2 metabolic distress indicating mitochondrial dysfunction, hyperglycolysis due to systemic fever, probe malfunction due to high protein collection. Please submit your answers. The answer is B, type 1 metabolic distress. Cerebral microdialysis uses a dual Ewing caster placed in the penumbral tissue surrounding infarcted or contused brain with a semipermeable membrane at its tip. As perfusate flow along the membrane with a CSF mimicking fluid, small molecules diffuse between the brain interstitium and the caster with the principle of dialysis. The substances present in an area of higher concentration across a semi-permeable membrane, it will diffuse to an area of lower concentration, allowing continuous sampling of extracellular metabolites for analysis. In this patient, the cerebral microdialysis profile demonstrates type 1 metabolic distress, indicating ischemic or hypoxic metabolic crisis. An elevated lactate pyruvate ratio greater than 25 in the context of very low extracellular brain glucose 0.3 millimole per liter and low pyruvate 50 micromole per liter, indicating insufficient substrate and oxygen delivery rather than preserved aerobic metabolism, while values of lactate pyruvate ratio exceeding 40 are strongly associated with cerebral ischemia. This pattern reflects a shift toward anaerobic glycolysis due to cerebral hypoperfusion, resulting in lactate accumulation and pyruvate depletion, with elevated glycerol and glutamate. By contrast, type 2 metabolic distress is characterized by an elevated lactate pyruvate ratio with a normal or elevated pyruvate, reflecting impaired oxidative phosphorylation despite adequate substrate delivery. Hyperglycolysis would present with preserved or elevated glucose and a normal or mildly elevated lactate pyruvate ratio, while probe malfunction does not produce a coherent metabolic pattern. In the clinical context of post-subarachnoid hemorrhage day 6 with severe MCA vasospasm on transcranial Doppler, this cerebral microdialysis profile strongly supports ongoing ischemia at the tissue level and is highly concerning for evolving delayed cerebral ischemia, warranting urgent hemodynamic and perfusion-directed intervention. In patients with traumatic brain injury, microdialysis caster is placed in the recoverable or salvageable area, not only to help in understanding the pathophysiology of injury, but also guides in the therapeutic interventions to prevent secondary brain injury. Sanchez et al. Studied 1,260 microdialysis samples from 12 TBI patients and analyzed them for glucose, lactate pyruvate ratio, and lactate glucose ratio. High extracellular lactate and low glucose were found to be indicators of severe neurological damage and poor outcome. Therefore, increasing the blood pressure or fraction of inspired oxygen or interventions to decrease the ICP can salvage the vulnerable tissue. In conclusion, type 1 metabolic distress will include high lactate pyruvate ratio, low glucose, and low pyruvate, indicating ischemia, and type 2 metabolic distress will include high lactate pyruvate ratio, normal or high pyruvate, indicating mitochondrial failure or dysfunction. And this table is showing the thresholds of various multimodality monitoring devices used in neurologic monitoring. It's showing the pros and cons of cerebral microdialysis, and it can measure the cellular level changes, but it needs hourly bedside sampling with a dedicated infrastructure. And the treatment thresholds include lactate pyruvate ratio more than 25 and more than 40. Both thresholds are reported for cerebral metabolic distress. Also, abnormal glucose below 1 millimole per liter, abnormal glutamate more than 20, abnormal glycerol more than 50 micromole per liter, all are treatment thresholds that need intervention. Case scenario 2. A 45-year-old male is admitted to the Neuro ICU after a high-speed motor vehicle collision. Initial GCS is 6, and a head CT shows diffuse cerebral edema with small bifrontal contusions. He is intubated and initiated on propofol and fentanyl infusions. While waiting for the neurosurgical team to place an invasive intracranial pressure monitor, you perform point-of-care structural assessments at the bedside. MCQ1. You utilize point-of-care ultrasound to measure the patient's optic nerve sheath diameter as a non-invasive surrogate for intracranial hypertension. Which of the following statements most accurately describes the evidence-based technique and clinical interpretation of the optic nerve sheath diameter in this setting? The measurement should be taken 5 mm behind the retina, and a diameter more than 4.5 mm is a standard diagnostic threshold for all patients. The measurement should be taken 3 mm behind the retina, and a diameter more than 5 to 5.9 mm is sensitive for detecting elevated ICP. Optic nerve sheath diameter is a direct measure of cerebral perfusion pressure and is more reliable than an EVD. A normal optic nerve sheath diameter measurement at admission provides a 100% negative predictive value, ruling out any future increases in ICP. Optic nerve sheath diameter is considered the gold standard for managing severe TBI because it is unaffected by individual optic nerve anatomy. Please submit your answers. And the answer is B. Ultrasound-derived optic nerve sheath diameter is a non-invasive surrogate used to detect acute intracranial hypertension in high-risk patients. The standard technique involves measuring the sheath diameter exactly 3 mm behind the retina. While specific cutoffs vary across studies, a diameter greater than 5 to 5.9 mm is generally correlated with high ICP, with sensitivity approximately 85 to 95% and a specificity of 70 to 85%. However, it is a not direct measure of pressure and cannot replace invasive gold standards like EVDs for precise titration or therapeutic CSF drainage. Its accuracy is also limited by operator dependence, probe positioning, and individual anatomical variations. So using optic nerve sheath diameter is the standard focus test we are using, but navigating the gray zone of borderline optic nerve sheath diameter with results between 5 and 6 mm, which is common and a challenging scenario in our practice. What is the next step in your exam? In these cases, some studies suggest sonographic assessment of papilledema manifested by elevated optic disc. This is not a standalone diagnostic test. Instead, it serves as complementary step in your focus exam. But we have to know that ICP elevation does not cause disc swelling in the acute setting, and it takes hours to days. So the absence of disc elevation does not rule out acutely elevated ICP, especially in a very recent injury. Its primary utility, when it is present, acts as a strong incorporating sign in a subacute or evolving picture. And in patients with TBI, the presence of both borderline dilated sheath and elevated optic disc increase the specificity of your ultrasound findings. And this is a video obtained from a patient ultrasound assessment showing papilledema or elevated optic disc. This is a suggested algorithm for evaluation of ICP elevation using ocular ultrasonography. When the optic nerve sheath diameter less than 5 mm, mostly it is highly suggestive for normal ICP. And when the diameter is more than 6 mm, highly suggestive for elevated ICP. And this is the gray zone we are talking about, 5 to 6 mm. We have to check a complementary step for presence or absence of papilledema. If there is no papilledema, so ICP probably normal. If there is papilledema, it will be highly suggestive that the ICP is elevated, especially if there is bilateral papilledema. And this figure is helped to differentiate between papilledema and pseudopapilledema. Pseudopapilledema, which means that there is optic disc elevation due to any other causes than elevated ICP. And also there will be normal optic nerve sheath diameter. In patients with normal optic nerve sheath diameter and no papilledema, this is mean normal ICP. In patients with enlarged optic nerve sheath diameter and no papilledema, this is suggestive for hyperacute ICP elevation. On the other side, in patients with normal optic nerve sheath diameter and there is papilledema, this is indicator for pseudopapilledema due to any other causes than elevated ICP. And in patients with enlarged optic nerve sheath diameter and with papilledema, this is highly suggestive for ICP elevation. MCQ2, an EVD placed that is reporting an ICP of 54 mm mercury. His blood pressure is 109/61. You look at the EVD and realize that the pressure transducer is mechanically fixed 20 cm below the level of the circle of Willis. Which of the following most accurately reflects the most appropriate interpretation of this EVD reading? The ICP is actually much higher. The ICP is actually much lower and no intervention is necessary. The ICP much lower, but the patient's cerebral perfusion pressure remains below 60 mm mercury. No accurate conclusion can be drawn since the transducer is not level. Please submit your answers. And the answer is C. For an accurate ICP reading, the transducer must be placed at the level of the foramen of Monroe, anatomic reference point roughly at the level of the circle of Willis. If the transducer is above the circle of Willis, then the pressure would appear lower than it actually. Similarly, if the transducer is below the circle of Willis, then the pressure would appear higher than it actually is. This is secondary to the effect of gravity in our atmosphere. Roughly, every 1 centimeter height difference will cause approximately 0.74 millimeter mercury error. Therefore, 10 centimeter difference will approximately cause 7.4 millimeter mercury error. And every 20 centimeter change in the height of the transducer from the level plane of what one is attempting to measure results in a change about 15 millimeter mercury in the pressure measured. This allows us to accurately correct for the error in the monitor and determine that the ICP is 39 millimeter mercury in this patient. Since this patient MAP is 77, so the cerebral perfusion pressure obtained by MAP minus ICP is actually 38 millimeter mercury. MCQ3. On post-injury day 4, despite tired ICP management, the patient remains comatose with GCS 4T, despite a stable mean ICP of 15 millimeter mercury. To aid in early neuroprognostication, you perform somatosensory evoked potentials. The results show clearly identifiable herpes point and N13 cervical responses, but the N20 cortical response is bilaterally absent. What is the most accurate clinical interpretation of this finding? The absence of N20 response is uninterpretable because the patient is receiving propofol infusion. The result indicates that the peripheral stimulus was insufficient and the test must be repeated using the posterior tibial nerve. Bilateral absence of N20 in TBI is uniformly predictive of a poor outcome with no reported cases of awakening. This finding predicts a 95% probability of progression to death or persistent vegetative state. Absent somatosensory evoked potential at 72 hours are less accurate than the motor component of the GCS for predicting long-term disability. Please submit your answers. And the answer is D. Somatosensory evoked potentials are obtained by electrically stimulating a peripheral nerve. Most commonly, we are using in our practice the median nerve at the wrist for upper limbs or the posterior tibial nerve at the ankle for lower limbs, and recording responses at successive levels along the somatosensory pathway. The recording electrodes are placed in 3 key sites at the brachial plexus or herpes point, at the cervical spine, and at the cortex on the contralateral side of the stimulated hand or median nerve. Waveforms are named by polarity and latency. Polarity N mean negative or reflected by upward deflection, and P, it will mean positive or downward reflection. And the latency represents milliseconds. So, for example, in 9, that means that in normal patients, at 9 milliseconds, we are expecting to get an upward deflection. And in 20, at 20 milliseconds, we are expecting to get an upward deflection. This is indicating the primary cortical response to the median nerve stimulation. The recording electrodes at herpes points will record N9 signal. This is generated by brachial plexus stimulation, which confirms peripheral nerve entry and showing that the stimulus of the median nerve has been traveled between the wrist and the brachial plexus. And the cervical electrodes will record N13 and P13 signals generated by the dorsal column. And the scalp electrodes will detect N18, N22, N20 signals detected by or generated by the stimulated cortex, and showing that the stimulus has been arrived to the cortex and the cortex is intact. The absence of somatosensory evoked potential N20 cortical waves remain one of the most reliable early prognostic tools for identifying unfavorable neurologic outcome in the evaluation of patients with severe anoxic ischemic encephalopathy. In the setting of TBI, the bilateral absence of the N20 cortical response performed at 72 hours post-injury or more is a strong predictor of poor outcome, with meta-analysis showing patients progress to this or persistent vegetative state in a 95% of the time. This is slightly less definitive than in hypoxic ischemic coma, for example, post-cardiac arrest, where a false positive rate is nearly 0%. In TBI, approximately 1 in 20 patients, about 5% with absent somatosensory evoked potentials, may eventually awaken, though usually with severe disability. Somatosensory evoked potential are notably resistant to the effects of sedatives and IV anesthetics at typical clinical doses, though affected by volatile anesthetics, making them a reliable tool even when clinical exams are confounded. And this is a somatosensory evoked potential recorded from the scalp and the neck after median nerve stimulation at the wrist for a normal patient, showing preserved or intact signal recorded at brachial plexus or Erb's point, and cervical spine showed by N13, and intact cortex with normal upward deflection at 20 milliseconds, showing N20 signal. And on the other side, there is a record from a 65-year-old male with absent cortical response after severe TBI who died without awakening, showing preserved brachial plexus signal, N13 signal, showing intact cervical medullary activity, but absent N20 signal compared to normal person. And finally, thank you for your attention.
MashaAllah, thanks so much, Dr. Ahmed, about this in-depth case discussion. Now, from the audience, there's a few very nice questions. For Prof. Kaira, there was a question about the actual impact on the outcome regarding the intracranial pressure. So is it the severity or the duration? Although previously there was an old study, I think, about the spinal cord injury, and they proved that duration is more harmful than the severity. So I don't know if it's the same for the brain or brain
It
sticking
could be.
something else.
Thank you for the question, first of all. I would say that both are important, but I will give you an example. If I have a patient who is being suctioned, and because of the suction, the ICP goes up to 30, but then goes immediately down. This is absolutely normal. This happens also to me when I get angry with my daughters. So this is not scary. It's much more scary when you have an increase of ICP at 20, 21 for a very, very long time. Because the point is the dose of ICP, not the number itself. That's my point.
Thank you. So the next question, there was also a case submitted by one of the audience that he's mentioning. So what are the suggestions for some troubleshooting that they have a patient with the brainstem bleeding and they want to monitor his ICP plus also the drain. And once they inserted the EVD, they find out that the bleeding extend to the third and fourth and even the lateral ventricles. So any suggestion regarding, first of all, termination of EVD and not using for monitoring because of the clot or?
Oh, well, if you have a brainstem lesion which can close the fourth ventricle and then, of course, give hydrocephalus, I believe that external ventricular drain with together ICP monitor is the gold standard. Also because in these conditions you have a local increased ICP in the brainstem and you cannot assess the local increased ICP in the brainstem. You can look with a transcranial Doppler whether this swelling affects the vessels. This you can do it for sure. But if you want to see the effect on the sovratemporal region, you have to put an external ventricular drain with an ICP monitor, or you can just put an EVD without ICP monitoring because, you know, in this case, you know that increased ICP is for sure because of the hydrocephalus for the closure of a fourth ventricle. So as long as you have a drainage, you know that you're treating ICP. So if you don't have the availability of a double systems, I don't think it's a big issue.
Prof. Robert, we have another question from the floor. This says in brainstem bleeds with extension into the ventricles, patient has an EVD, so how are we going to measure the ICP?
There are systems which can contemporarily measure ICP from the EVD. And this will be the gold standard. And again, because the mechanism of increased ICP is the hydrocephalus, I believe that is the gold standard. If you're asking whether you will put an intraparenchymal probe, I think you can, but I mean, if the cause is an increase of the ventricles, this means that you have to put a ventricle there, and it's not a parenchymal issue, if not as a secondary issue. My suggestion is just to, if you don't have this system which contemporarily measure ICP and as an EVD, to leave the EVD at the height of the meatus and let it drain. Let it drain and check it with the clinical picture and with the neuroimaging.
We have another question here from an anonymous attendee. The question is, do you recommend routine invasive ICP monitoring, epidural bolt? I think they wanted to say skull bolt.
Yeah, I understand that there are, so you can put the probe in the extradural, subdural, or intraparenchymal or intraventricular. What we have learned from the literature is that the subdural and the extradural have a lack of accuracy. And a retard in looking at the increase of ICP. So I will not recommend it. I would recommend as gold standard the intraparenchymal or the external ventricular drain.
Thank you, Prof.
So there's, I think, one last one from my side. There's a question about the brain tissue oxygen tension. Is it usually more accurate to give the global ischemia of the brain or the oxygen delivery, or it's used mainly for the regional, if you want to check like a regional area?
So PBTO2 gives you an idea of the regional oxygenation. And this is why it's very important to have a good collaboration with the neurosurgeons who have to put the PBTO2 in the penumbra area. So the area which is more at risk of desaturation and ischemic risk. Of course, the problem is that there is not a global issue. I mean, it's not a global information, but it's the information of the most vulnerable part of the brain.
And just lastly, about the jugular bulb oximeter, it sounds much easier than the rest of the invasive devices. But is there a way to be like measure the correct positioning? Because I think this maybe will be the struggle in the ICU if we don't have like frequent imaging for the patient or expert. So it might be sounds like it's an easy way, not that invasive. But about the positioning, I think we are all maybe will be struggling about the positioning.
The position is fundamental because if you put it in the wrong position, you can get information as fascial drain of the fascial vein, and this is not intracranial. So there are some landmarks, of course, but I suggest a check with a radiological check to make sure that the position is correct. On the other hand, from a practical point of view, it's not that difficult. It's not that difficult at all to put it because it's like to put a central line, but in a retrograde way. The difficulty is to find the right distance, but if you use a radiographic check, it's not that difficult.
Very nice. Thank you so much, Professor Kaira Ruba, for this very nice presentation, and Dr. Ahmed Lotfi for this very informative case-based discussion. Thank you so much, Dr. Ayman Morayesh and Dr. Akinola for the great moderation. And of course, we thank our audience, more than 300 audience from all over the world who came in today to learn. And I think what we learn more is what we ignore is much more than what we know. So we need to learn, we need to study, we need to dig deeper. With that, we are going to close our today's webinar, and hopefully we'll see everyone in our next month webinar. All attendees should receive certificate of attendance by next week. And by tomorrow, all of you should get the YouTube recording of this webinar. Have a good rest of your day, your afternoon, your night. Bye.